In this video, we will explain the open reduction and internal fixation of zygomatic complex fracture. It is very difficult to decide to use a 1 point, 2 point, 3 point, or 4 point exposure and fixation of the zygomatic complex fracture. It will depend upon the uh, experience of the surgeon and the technology available for the surgical procedure. Now, as far as the radiographs and CT imaging is concerned, it can be used by the degree of the fracture displacement. Second is the comminution at the buttresses. And third is the status of adjacent buttresses, including naso-orbitoethmoidal area. Uh, and also you can assess the status of orbital floor, because these factor will depend on your management planning for the zygomatic complex fracture. Now, first question arises that how many areas are involved in the zygomatic complex fracture. It can involve only a frontozygomatic area, infraorbital area, or it may involve the zygomatico-maxillary area or zygomatic arch area. The treatment will depend upon how uh, much areas of the zygomatic complex fractures are involved. And apart from these 4 points, there is important that is the status of the orbital area. That is the orbital wall. Orbital wall means lateral orbital wall or the orbital floor, this area. This may be comminuted, lateral orbital wall may be comminuted, and similarly, the orbital floor, blow in, blow out fracture may be seen. Sometimes the orbital floor fracture may be isolated, but in most of the cases, it may be associated with the zygomatic complex fracture. Now, isolated zygomatic arch fractures also occur, and these are not associated with the ZMC fracture. Most commonly, you will see the frequent comminution with inward displacement at the mid-arch, as we see in the previous video, is a V-shape zygomatic arch fracture. It will lead to a localized contour deformity or dent in the cheek area. And the important thing of the isolated zygomatic fracture arch area is that no orbital component is involved. Usually there is no fixation of zygomatic arch is required with the plating, and only simple elevation will lead to a treatment. Now, how you will decide for the management of the zygomatic complex fracture? As we have discussed that how many buttresses are involved in the fracture area. So how you will approach is, how you will expose is, what will be your surgical access, and whether their requirement of coronal approach or coronal surgical access will be required. It is required when the comminution and outward displacement of the zygomatic complex is involved. And second thing is when the you want to expose the zygomatic arch because it is involved in the fracture, and you want to use it as a landmark for the reduction of the zygomatic complex fracture, or you want to place a plate over the zygomatic arch area, then the coronal approach is mandatory. And how much fixation, whether you can achieve it with a simple reduction. There is no need for the open reduction and fixation. It is 0 point fixation, or 1, 2, 3, or 4 points. And this often dictated by combination and severity of the fracture. As we discussed in previous slide, that whether to explore the orbital floor, and when the fracture lines extend medial to the infraorbital nerve area, and there is a blowout fracture, that is a fade herniation is seen in the maxillary sinus on the radiograph, then it means that the orbital floor must be explored in the zygomatic complex fracture. And the recommendation for the fixation from 1 point to 3 or 4 bone plates, that is mini or micro, or you can also use a transosseous wiring at different locations of the fracture area. You can place the plating at the frontozygomatic suture when it is separated, and plating at the infraorbital rim can be done. And fourth is the zygomatic-maxillary buttress and the zygomatic arch area, if these areas are involved. Now come to the 1 point of fixation of the zygomatic complex or fracture. In some situations, a surgeon may have a simple non-comminuted zygomatic complex fracture. This has often been achieved with the maxillary vestibular approach. This approach allows visualization of both the maxillary buttress area, this is the maxillary buttress area, and infraorbital rim, particularly in patients where a CT has revealed no separation at the fracture of the zygomatic-frontal suture. You will not see any separation of this area, and with good intraoperative visualization and reduction of the lateral maxillary buttress and infraorbital rim, 1 point fixation with a plate between the maxilla, this is the maxilla, and the zygoma may be adequate. You can, apart from the maxillary vestibular approach, you can use an existing laceration for the surgical access. This is a 1 point. Now come to the principles of rigid fixation for 1 point fixation without involvement of the orbital orbital fracture, or you can say without orbital reconstruction. Correct anatomical reduction is required for all fractures. So this is the key, this is the basis of the all fractures. So correct anatomical reduction to a pre-morbid condition is important. And second thing is the proper alignment of the orbital wall, because this will give you a guideline for the reduction of the ZMC fracture. When the orbital walls are in a properly reduced, then it means that you can achieve a proper reduction of the ZMC. In order to achieve the proper reduction of lateral orbital wall, which is the landmark for the reduction of the zygomatic complex, what you will do, that the greater wing of the sphenoid and zygoma must be properly aligned. When these two structures are properly aligned, it means that you have properly reduced the orbital wall, which is a landmark and which will show you that you have achieved a proper reduction of ZMC. Now, what is the aim? Aim is to restore the proper orbital volume. Second is to restore the proper width of the face, that is the anterior-posterior projection, and also the height of the midface. Now, when you will do the proper reduction of the zygomatic fracture, then the problem of this AP projection and width of the mid face will automatically will be resolved by the proper reduction of the zygoma. It is possible that the periorbital contents may have been affected by the reduction of the zygomatic complex fracture. So force reduction test must be performed before and after the reduction of the zygoma, so that make sure that there is no entrapment of the inferior rectus muscle, or you can say inferior oblique muscles in the orbital floor. And second thing is the pre and post operative eye examination must be done in such patients. Now come to the zygomatic reduction method. The first step is to obtain a proper 3D reduction of the zygoma. And now we have discussed in our previous video that you can use an elevator, a hook, a screw, or a Carroll Garrett type device to mobilize or reduce the zygomatic complex fracture in its original position. For this reduction method, you can use the keen approach, that is the transoral approach, or the incision may be done in the maxillary vestibular area, and you can use an elevator or a hook for the reduction purposes. Alternatively, you can use the Carroll Garrett screw for the reduction. Now, come to the fixation, placement and fixation of the plate. Now, looking through the maxillary vestibular approach, the fracture of zygomatico maxillary buttress is reduced, or you can say is aligned. Now, a large L-shaped plate is ideal for the fixation of this fracture. Second important thing is this is the most difficult plate to properly adapt in zygoma fracture. So it is important that the leg of the, this is the leg of the L plate be placed on the most lateral portion of the lateral maxillary buttresses, where the fairly a thick bone is available here. You can see here. Now, it is similarly important that the foot of the L plate, this is the foot of the L plate, is placed along the alveolar bone in a manner that the screws will not be placed in the dental roots. You will avoid the dental roots. Here you can see, you will avoid the dental roots. So it should be placed in such a way that it is away from the dental roots. Resulting in a screw placement. Sometimes what happens that a common problem which occurs in this plate is that the failure to properly adapt the L plate, and it will result in screw placement into the thin wall of the anterior maxillary sinus, and it can be comminuted. Sometimes this lateral maxillary buttress can be comminuted. So in such a case, a longer L plate with multiple screw, longer, so that you should be away from this comminuted area of the maxillary sinus. So a longer L plate with multiple screw holes may be ideal. And second thing is always use a stronger plate for zygomatico maxillary buttress area. Here you can see the plate has been fixed according to the principles that we have explained. Now here you can see that use an L-shaped plate in zygomatico maxillary area in order to avoid damage to the apices of the teeth. So such a straight plate is not recommended, and LT and Y-shaped plate should be used here. Now come to the two-point fixation for the zygomatic-maxillary complex fracture without orbital reconstruction. All the principles which we have explained in the previous slides will applied. We will further aid the key landmark that is the alignment of the greater wing of the sphenoid and the zygoma to form the lateral orbital wall, because this lateral orbital wall, as we explained, that this is a landmark for the reduction of the zygoma. This landmark should be visualized by the surgical access, and then it should be properly reduced. Uh, um, but this landmark is not reliable when it is communicated. Then you will see the other landmarks which will be explained in the next slides. Now, as we said that the all principles which you explained for the one-point fixation will apply. Now we will come to the selection of the surgical approach. That is a maxillary uh, vestibular approach must be made to visualize the fracture at the zygomatico-maxillary buttress. And if the fracture at the fronto zygomatic suture area is displaced, an upper eyelid incision must be made. This incision also provide excellent visualization of the sphenozygomatic suture area within the orbit. This combination, that is the maxillary vestibular approach and an upper eyelid in approach, that will provides an excellent exposure for the 3D reconstruction of displaced zygomatic complex fracture. Now, we will not explain again the zygomatic reduction methods. These are similar as we explained for the one-point fixation. Now, as far as the uh, placement and fixation of the plate is concerned, the first plate is placed across the frontozygomatic fracture area, and it is recommended that a minimum of 5-hole plate with 1 hole spanning the fracture line should be used. The plate should be properly adapted. Now, adaptation of this plate is very important. It should be properly adapted, and one screw is placed in an unstable zygomatic fracture area. Suppose this one is unstable, then you will place one screw here in this unstable zygomatic fracture, and then an instrument is then used to pull the plate and the zygomatic fragment in a cephalite direction, to further reduce the fracture. This maneuver is used for the reduction of the fracture in a proper position. Only one screw should be placed on each side of the fracture in the holes nearest to the fracture, in these holes, because these are the near to the fracture. Now, the surgeon should verify the proper 3D reduction of the zygoma at the other 2 points while fixing the other screws. Uh, so it should be fixed later on. That is the first final two screws, sorry. When you will place one screw on each side of the fracture line, then you should see the reduction of the other points if they are fracture, because we are considering the 2 point. So the other point should be reduced properly, and then the final two screws in the zygomatico-frontal plate should be placed at the end of the intervention. It means that you will properly reduce the zygomatic fracture at other points. Then you will finally place the other two screws. Here you can see that the fixation of the plate is being done, and finally the plate has been fixed here. Now, placement of the additional plates. Looking through the maxillary vestibular approach, the fracture of the zygomatico-maxillary buttress is aligned. And we have described the principles of placing this plate in the zygomatico-maxillary buttress area, so we will not repeat. All those principles will applied, and as we said, that this is the most difficult plate to properly adapt in the zygoma fracture. Now here you can see that the placement and fixation of the this additional plate that is the zygomatico-maxillary buttress area is seen. And now we recommend that the low profile plate should be used at the frontozygomatic area, and a stronger plate is recommended here. And a stronger plate is recommended for the zygomatico-maxillary buttress area. To the 3-point fixation, all the principles which are described in the previous slides will apply to 3-point fixation as well. However, we will explore one point regarding the orbital floor reconstruction. In a zygomatic fracture that requires orbital floor reconstruction after exposing the zygoma and orbital floor, it must be noted that the zygoma should be disimpacted prior to dissecting the orbital floor, that is the herniated tissue that is present in the maxillary sinus due to the orbital floor fracture. So the first step is that the zygoma should be disimpacted. In a fracture of this nature, the reduction and fixation of the zygoma should be performed first. Reconstruction of orbital floor should be performed after the zygoma has been reduced and stabilized. So after the reduction and fixation or stabilization of the zygoma, you must go for the orbital floor reconstruction. And now we will come to the order of reduction and fixation. So the first plate you will place that is on the frontozygomatic fracture area. Um, it is debated whether the second site for fixation should be the orbital rim or the zygomatico-maxillary buttress area, but normally the second plate is placed on the orbital rim and the third one on the zygomatico-maxillary buttress. A smaller plate is recommended for infraorbital rim. A larger plate, commonly an L-shaped plate, is recommended for the zygomatico-maxillary buttress. Uh, Second thing is selection of approaches. Three approaches are required for this procedure. So the commonly include an intraoral maxillary vestibular approach, a lower eyelid incision that is transcutaneous or transconjunctival, and a coronal incision with direct exposure of the zygomatic arch and the lateral orbital region. Existing laceration may be used. So intraoral maxillary vestibular approach facilitate the exposure of lateral buttress of the midface. It can also be used to expose the infraorbital rim. The lateral maxillary vestibular approach uh, can also be used to help reduction of the depressed zygoma. The lower eyelid incision is ideal for exposing the orbital floor, the orbital rim, the lateral orbital wall. The coronal incision is ideal for exposure of zygomatic arch, lateral orbital rim, that is frontozygomatic suture, lateral wall of the orbit, that is phenozygomatic suture, and can also be used to harvest the split carvallial bone graft. Um, The lateral orbital wall can also be approached via the lower eyelid incision, that is transconjunctival or transcutaneous, or the upper eyelid incision, that is a blepharoplasty incision. It can also be approached via a coronal incision if a coronal incision is otherwise required. Uh, the zygoma reduction methods has been explained in the previous slides. Now come to the fixation of the plate. So the first plate is placed across the frontozygomatic area. A minimum of 5 whole plate is recommended. As a general principle with all plate fixation, at least 2 screws should be placed on both sides of the fracture line. This often requires a plate with at least one extra screw to span the fracture. Ideally, the first screw should be placed on the side of the mobile fragment and plate used as a handle to close the gap and reduce the bone. This has been described also in the previous slide. The first 2 screws should be placed in the plate closest to the fracture, one on each side of the fracture. Make sure that the fracture is adequately spanned so that each screw is placed in a solid bone. It must be placed in the solid bone. Only one screw should be placed on each side of the fracture in the hole that is nearest to the fracture until the surgeon has verified the proper 3D reduction at other points, at other points, that is at the infraorbital rim and at the zygomatic-maxillary buttress area. Now, the second plate should be placed on the orbital rim, and then the third placed at the zygomatic-maxillary buttress area, that is a larger L shape is recommended. Now, we will see here, when looking through the lower eyelid incision, the infraorbital rim plate should be properly adopted. Use a minimum of 5 whole plate with extra holes spanning the fracture line. Reconfirm that the lateral orbital wall, that is the greater wing of the sphenoid and zygoma, has been properly reduced prior to placing, adopting, placing, and fixing this plate. And now looking through the maxillary vestibular approach, the fracture of the zygomatic-maxillary buttress is aligned. A larger L-shaped plate is ideal for the fixation of this fracture. The rest of the principles has been explained in the previous slide. Now, the last is the 4-point fixation. The 4-point technique is unique from the 3-point technique in that the surgeon has visualization of the zygomatic arch, because we have to take the coronal approach for the zygomatic arch, and zygomatic arch can be useful in achieving the proper width of the midface and AP projection of the zygoma. It should be noted that the zygomatic arch is not a true arch and is often relatively straight in its central portion. Accurate positioning of the zygomatic arch addresses the AP dimension and width of the face. Now coming to the selection of approaches, the 3 commonly used approaches, maxillary vestibular approach and lower eyelid incision and coronal incision is described for 3-point fixation. Zygoma reduction methods are the same as previously described. Now, if the lateral wall of the orbit is not comminuted, that is the most important landmark to determine whether the proper reduction has been performed. Whenever possible, the surgeon try to achieve a perfect reduction of the lateral wall of the orbit, and This requires the alignment of the greater wing of the sphenoid and zygoma. If this reference point is communicated, then the order of placement of the other three plates will depend upon the landmarks that are least uh, damaged. Zygomatic arch may be an excellent reference as to whether the proper AB projection of the mid face has been restored. However, in cases where the arch has been fractured and displaced at several different levels, the use of arch to reposition the zygoma may be less reliable in such cases. Now come to the order of reduction and fixation. In a fracture of this nature, first is the placement of the frontozygomatic fracture area. You will place the plate here. And second is the area of zygomatic arch. Third is the orbital rim. And fourth is the zygomatico-maxillary buttress area. In this fracture, the reduction and fixation of zygoma, including the zygomatic arch, that is the zygomatic arch, orbital rim, and zygomatico-maxillary buttress area. This one, you can see here, this one should be performed first. All these 4 points fixation will be performed first before the orbital reconstruction. Reconstruction of the orbital floor should be performed after the zygoma has been reduced and fixated. So the first step should be the placement of the plate or wire at the frontozygomatic suture area. Now, looking through the coronal incision, the zygomatic plates should be properly adapted. Use a minimum of 5 hole plate with extra holes spanning the fracture line. Reconfirm that the zygomatic arch has been properly reduced. Prior to placing this plate, a minimum of 2 screws should be placed on each side of the fracture, as we have explained. That is the general principle. Prior to securing this plate, make sure that the reference point of the lateral orbital wall, infraorbital rim, this one, and the lateral maxillary buttress area, these are properly reduced. Here you can see that the all areas should be properly reduced. As a general principle, if one reference point is communicated, then general principle is to begin with the reference point that are least communicated. At the same time, it is important to have a wide exposure of all the reference points and to recheck the reduction of each reference point as each new plate is placed. Extreme care should be taken during the dissection around the zygomatic arch so as not to injure the temporal branch of the facial nerve. This nerve lies very close to the periosteum of the zygomatic arch. Many surgeons argue that the potential cosmetic defects caused by this coronal approach to the zygomatic arch are worse than the defect of a minimally displaced arch. These cosmetic defects include alopecia from the coronal scar, a risk of the injury to the temporal branch of the facial nerve, as we have described now, and the temporal hollowing. It means that if the defect due to the zygomatic fracture is minimal, then you should not go for the open reduction and fixation. Next is the placement of the third plate, that is the placement of plate at the infraorbital area, and the fourth plate at the zygomatico-maxillary area. These are the principles regarding these plates have been previously described. You can see here all the 4 points has been fixed with the plates, applying the principle just described. Here you can see a zygomatic arch. Uh, so, post-operative positioning of the patient, keeping the patient head in an upright position, both pre-operatively and post-operatively, may significantly improve periorbital edema and pain. Thank you.